Hello, and welcome to today's health webinar. Today's episode is brought to you by your friends at DaVita. We would like to remind you that the Q&A feature is available, so feel free to send in your questions and comments throughout today's webinar. We would love to hear from you. And with that, I will turn it over to our moderator, Dr. Jeff Gillian.
Excellent. Thank you so much. I appreciate the opportunity to join today. My name is Jeff Gillian. I'm a nephrologist from Denver, Colorado, and I'm the Chief Medical Officer of DaVita. DaVita is a large kidney care organization. We take care of patients throughout their kidney care journey, from chronic kidney disease to dialysis to transplant here in the United States, and also across the globe, South America, Europe, and Asia. And I am joined today by three phenomenal guests. I cannot wait to get into our discussion today as we discuss the care of patients with multiple chronic diseases, polychronic disease, as it's sometimes noted. And we talk about how we can come together to help entire communities with this. So in just a minute, I'll invite each of my guests to introduce themselves, but let me just give a quick introduction of each of them because I'm so excited to have each of them with me today. First, let me start with Juliana Crawford. Juliana is a part of the American Heart Association, something that's near and dear to my life. My wife is a cardiology nurse practitioner and has been an AHA member for her entire career. So really grateful for the work that you do. And of course, patients with kidney disease and patients with heart disease overlap so much. It's not one or the other. These two organs really do rely on one another. Next, I'm joined by Dr. Gloria Winters. Gloria is the Chief Health Officer for the YMCA, and I'm equally feel blessed that we've got a partnership between DaVita and the YMCA. I got to spend some time at our Baton Rouge YMCA recently, where we did an entire community event screening people in the community for things like diabetes and high blood pressure and kidney disease. What an absolutely fulfilling day it was for me to be able to do that. And then also joined by Dr. Tiffany Crank from the American Diabetes Association, another partnership that we have. Again, it's not just heart disease and kidney disease, but it's heart disease, kidney disease, high blood pressure, and diabetes that go together on this metabolic spectrum. So very fortunate to have all three of you with me today so that we can talk about really improving the health, not just of individual people, but truly improving the health of communities. So Juliana, maybe we'll start with you to do a quick introduction, and we'll go around to Dr. Winters and then Dr. Crank as well, and then we will get started. I'll ask you guys lots of questions.
Sounds good. And so good to hear about your wife's dedication to the organization. We really appreciate leaders like your wife volunteering for the organization for so long. So my role at the American Heart Association, I sit at the National Center based here in Dallas, and my department is really in charge of solving problems that require the full power of the organization behind them. Not any one vertical can solve the problem. So things like food as medicine, where there's a science and a policy and a community and a consumer marketing component, things like our cardio, kidney, metabolic health work, which again requires all of these different departments and different strategies kind of strung together in an integrated and connected way. So we're kind of a hub of a wheel on solving these big problems like those examples there.
Yeah, that's great. So lucky to have you with us. Dr. Winters, why don't you go next?
Yeah, thanks so much for having me, everyone. So Dr. Gloria Winters, Chief Health Officer for YMCA of the USA. I've been a practitioner here in Colorado for over 25 years. And as a brief intro as to why I came over to the YMCA is I was treating patients full-time, managing practices all across the Front Range. And what I began to see was it was becoming harder and harder to give good patient care. And so I began to imagine what would that look like in order to achieve whole person health. And as we know, the CDC says that health is defined as 20% clinical care and 80% behavioral, physical, and socioeconomic factors. In addition, we see that the World Health Organization defines health as a state of complete physical, mental, and social well-being, not merely in the absence of disease or infirmity. And so in those definitions, I began to think, what would that really look like to bring those two together? So my role now at the YMCA of the USA is to really bring business models and partnerships together to bring that whole person health together.
Excellent. Thank you. Thank you for joining us, and thanks for the partnership that we have with your organization. And Dr. Crank, why don't you introduce yourself as well?
Yep. Absolutely. Thanks, Dr. G. And good afternoon, good morning to some. I'm very happy to be here today. At the American Diabetes Association, I have the privilege of serving as the Senior Director of Health Access and Quality. And essentially, in my role, what I have the opportunity to do is to lead national and local strategies that really advance health access through community-driven initiatives. You know, those initiatives focus on diabetes, they focus on obesity prevention, clinical trial education, improving access to quality healthcare. So essentially, my work really involves bridging health systems and community organizations and using evidence-based frameworks to really ensure that our resources and our interventions are being responsive to the communities and the people that they're meant to serve. Yeah, so happy to be here.
Fantastic. I appreciate you being here. So maybe I'll start with you, Dr. Crank, and then we can kind of play off of one another. But obviously, you just brought up the work that you all do, working with other organizations to raise awareness and more than that, to prevent disease, especially when it comes to diabetes. And I would love to hear just how you think about chronic disease prevention in general. As a community approach. Obviously, it's patient-centered or person-centered because not everybody even knows they're a patient when we first interact with them. But how do you think about this and leading from a community standpoint?
Yeah, great question. And when I think about community-led and continuing person-centered chronic disease prevention, it's really a shift of us doing things for communities to doing things with communities, to making sure that when initiatives are developed, when they're implemented, that they're rooted really in the lived experiences of the communities that we're serving, and that they implore elements of the cultural relevance to make those initiatives almost curated, right, for those particular communities that they'll be in. When we do that, that really gives us leverage to do several things. One, build trust. We have the power to catalyze our trust building in communities when we're inclusive of community voice. It gives us the ability to drive sustained behavior change. So when communities, again, are a part of the solution development, that creates more sustainable solutions that can live on in that community far beyond our organization or, you know, any of those things. And then it gives us the opportunity to address those systemic barriers head on. I mean, communities face very unique and specific challenges that may not fit a one-size-fits-all solution to healthcare. So essentially, you know, community-led, community-driven is really tailoring those interventions so we're sure that they resonate to the people that we want to serve, and that they can create some impact in real-world settings. At the ADA,
Man,
we really try. Oh,
oh,
go
go
ahead.
ahead.
No, I was going to say we really just try to make it a point to be intentional about including that that element in all of the community initiatives that we develop and implement.
Yeah, I mean, it resonates so much with me, this idea of working with communities, not just for them. And, you know, this is an area of healthcare, I think that generally in medicine, we as physicians, we as clinicians have been moving towards, which is meeting our patients where they are. And for you to say that about our communities as well, just absolutely resonates because what works in one community may not work in another community. And so involving the community in their own care, meeting them where they are, meeting their needs, having cultural awareness is just absolutely highly profound. And I know it's something that you, Dr. Winters, and the YMCA are heavily focused on is serving each individual community individually. Would love to hear a little bit about your thoughts on that.
Yeah, Dr. Crank said it really, really well, right? Culturally relevant, meeting people where they live, work, and play, breaking down those systemic barriers. But what does that actually look like, right? And so I'll give just a quick example. One of the ways that we do that with our diabetes prevention program is partnering with a group called Servicio de la Raza, so Services for the People. And they use their promotoras, right? Use our space because it's a trusted area at a YMCA. We help to provide access to our location, sometimes through various transportation services to get them there. But as Dr. Crank says, If I came in and taught that, it would not be culturally relevant. When we have their local promotoras do it, the kids show up, the families show up, the husbands and the wives are both involved. And that's actually what leads to behavior change. Because as we know in this chronic disease space, it's chronic. It's not acute. It's the long game. It's not the short game. And so we really need to do something that gets them habitually changing lifestyle changes and providing membership at the YMCA as part of that, along with that diabetes prevention program in a manner with Servicios de la Raza, where the promotoras are actually doing the teaching, the facilitating. So we've seen in that component, it's actually become something that is then lived in the community. So it's really, really a key piece to changing that long term.
Yeah, makes sense. And I was just realizing as we're sitting here, you guys are all so well lit, and I look like I'm in the witness protection program with this funny lighting. So I'll just apologize to anybody out there. I'm not trying to hide like half my face, but it certainly looks like it. Moving on, though, to more important things than my face, Juliana, kind of picking up on this, as we talk about specific communities, obviously what comes to mind is the social determinants of health. There are vulnerable populations that we all seek to serve better, and reaching out and doing this in, as terms we've just used, culturally sensitive manner, and understanding social determinants of health. Would love to hear from your perspective and the American Heart Association's perspective what some of the biggest barriers are to reaching people that are at risk for cardiac disease and other chronic diseases.
Absolutely. It's a great question. And I think just hearing Tiffany and Gloria talk about their approaches, we're very much like-minded organizations into how we're doing work on the ground together. I think we have very similar, or we have the same strategic approaches, which is why we're often linked arms with local YMCA staff and staff in the American Diabetes Association. But what I would say in terms of the commitment to understanding the social determinants of health, I think it starts with understanding at the point of clinical care. And that is a gap. And so while we're doing all of this work at the grassroots level and building these strong relationships with community partners and linking systems, the Heart Association is also thinking about training up physicians from the start when we're writing clinical guidelines to ensure screening for social determinants of health is the first step in assessing patient populations. And so, from the top down, we're ensuring that every guideline that we write to drive clinical care across the spectrum of cardiovascular disease and stroke and brain health and areas in which we have expertise, that's the first step. And I think the other important thing that the organization has done over the last decade or so, I'm really proud of, is when we are developing those clinical guidelines, we are including lay people with lived experience on the writing groups next to clinical experts to ensure that lived experience, that voice is coming in from the very beginning. So as we're pushing out how do we implement these kind of guidelines in the real world, that the first step is understanding where people have barriers so they can be referred to community support and all the systems we're working to put in place at the community level. So really starting from the very beginning so we can push that out and make it kind of a part of the cultural norm of the way things are happening at the point of care.
Starting to feel a bit of a theme here, patient-centered, person-centered, community-centered, lived experiences, all of these terms that, quite frankly, as a physician, I probably need to be better at thinking about on a regular basis. So love the fact that you guys are embedding people who actually live with these illnesses with the scientists who are writing the guidelines, so that as physicians, when we're reading the guidelines and we're trying to follow the guidelines, we're doing so in a truly person-centered way. So really appreciate you guys being on the leading edge of that. And Dr. Crank, maybe I'll just kind of pose the same question to you and the American Diabetes Association. We know that social determinants of health, or sometimes called social drivers of health, do get in the way. They are barriers occasionally for patients being engaged in their own care, either being, understanding what illnesses they have, or seeking access to that, seeking access to that care, or ultimately then helping themselves partner with their healthcare provider to move them along the spectrum of greater health. And would love to hear how you guys go about trying to overcome some of those social determinants.
Yeah, absolutely. I mean, in addition to, ADA has the standards of care, and Juliana did such a wonderful job speaking of how we can incorporate some of these things into the clinical aspects of the guidelines that we're creating. So I'll talk a little bit more about the community facing, the implementation pieces. And when I think about this, you think about hierarchy of needs, right? When we think about those social determinants of health, often prevention and health prevention is trumped if there are other competing priorities for that person. So they won't be able to focus on health prevention if they need other more immediate things like food and housing. And so what I'll add to this part is with a lot of our community initiatives, what we do is incorporate a component to make it comprehensive, right? They may show up for diabetes or obesity or resource and have these community clinical linkages, but how can we also layer in being able to service some of their more immediate needs? Because we know they won't care about our clinical linkage or our obesity prevention if they're hungry. So, in a specific example, we are developing these community hubs that will be, this nucleus of resources for people in certain communities that we've selected. But we know we can't just provide the obesity, the diabetes information. We're being very intentional about layering in connections to those points of social care to make sure that a person can be served comprehensively, even right there in their own community.
I think if I'm sort of reading between the lines, what I'm hearing here is you're building trust. You're building trust with the people that you serve. And so I want to get into that. But before I do, just a couple of thoughts. Number one, to anybody in the audience, if you have questions or comments or anything that you want to get in, please feel free to do that. Jump in with the Q&A line and the chat line. Let us know what you're thinking and what questions you have. I want to take this idea of trust and open it up a little bit more and get your all's thoughts on this. And I should say that back in my institution, people call me Dr. G. And as I've learned in the YMCA, people call Dr. Winters Dr. G. So from one Dr. G to another Dr. G, how does the YMCA build trust in a community? Obviously, you are directly there. You are in the communities that you serve, brick and mortar. But how do you go beyond just being present and truly building trust?
Yeah, that is core to who we are as people, whether we're the YMCA or any of these other organizations represented, both attending and of course speaking on this call. We need, as humans, we are relationship-centric people. We want to belong to something. We want to be part of a system that has trust and connectedness. And so it is really key that as we develop these relationships, we are intentional about creating business models that actually gear into something that has trust and connectedness. So it's not just for the sake of creating a business to address diabetes or cardiovascular issues or any chronic disease issues for that matter. It's really about digging into what does that look like to create trust. Part of that is bringing in people that have lived experience. So at all of our YMCAs, as you said, it's so community centric. Our boards are made up of those local people, right? And so as we're establishing our strategic plans, our business models, it is made up of people that have lived experience in that. One of the things that I think all of us on this group are doing are looking at the community health worker. The community health worker is that intermediary position that can connect, if you will, the sick care to the health and wellness and prevention. And they're the ones that have the lived experience so that I can connect with you, Dr. G, and say, oh, this is actually what you need. And I know that because I come from that experience. Those are really key ways for us to tangibly connect those to the things that they need and create that trust.
So from one Dr. G to another Dr. G, this is why I love these partnerships that we have with all of you, because we continue to learn and grow. And, we're thinking about community health and you're thinking about, business related programs to make sure that your community health outreach is successful. So I love that. And community health workers is one where we, based on the work that we've done with you all and with others, it's an area we're leaning into as well. And it comes back to this theme of trust and meeting our patients where they are and giving them the resources that they need to be actively engaged in their own care. And so maybe, Dr. Crank, I'll just go back to you, and then Juliana, I'd love for you to share as well. each of your organizations is known for the trust that you have in society. People look to the ADA, they look to the AHA, not just for scientific guidance like I do as a physician, but for guidance in general about our general health. But again, when you're building that trust at a national level, that's important. Building that trust at a local level so that you can actually impact care at a local level is a different thing. I would love to hear, Dr. Crank, how you guys have done it, and then Juliana as well.
Yeah, absolutely. And Dr. G hit the nail on the head when she said the trusted messengers. That is certainly some of the secret sauce when it comes to engaging communities, finding the people, because it's not always the message. Sometimes it's the messenger. So starting with people and organizations that have established trust and leveraging the trust that they have already built. I mean, a perfect example is how we can empower our faith communities. We can go in as ADA or a hospital or whoever and say this, and people may or may not connect with that. But if we go in and connect with the local pastor that then shares the same message with their congregation, again, sometimes it is the messenger. And so our approach really is to find those champions, find folks in the community that can serve as the trusted messengers and empower them, use capacity building to build those organizations, build those people to be able to be the voice of the education and the initiatives we want to do. But I'll go back to just very first thing when we're talking about building trust in communities is first we have to make ourselves trustworthy, right? I think we talk about building trust with communities and how we want communities to trust. But as an organization and as healthcare professionals, we have to make sure that when people do show up, when they do come, when we do break down that wall, that we are ready to serve with compassion and cultural humility and understanding that there's different contexts and perspectives that people will show up with. And once people do come, once we're able to bridge those trust barriers, making sure we're ready to build and leverage that relationship and not, create any additional barriers by not providing the right perspective of care for them. So those two things, and engage. I mean, we've talked a lot about engagement. I'm sure we're going to have so much more conversation about engagement, but that is the additional secret sauce is crafting with communities and not for communities and being intentional about that.
Yeah, I love this idea of finding champions in the community to amplify your message, amplify the voice. So important. Juliana, what about you all at the American Heart Association?
Yes, it's funny, as I was thinking about this question, I was reflecting on in 2024, the American Heart Association celebrated our first century of work, 100 years of work. And so, as you can imagine, in that year or so, we spent a lot of time thinking about the future of the organization, but also spent a lot of time thinking about what are elements of the organization that will never change. And what we talked about there a lot was our commitment to accelerating the science and the grassroots infrastructure of the organization. And what that really means is our commitment to investing in staff that sit at the local level to do just the kinds of things that Dr. Crank and Dr. Winters have discussed about. Folks that are focused on community impact strategies and building relationships that come from the community, that sit in markets and across rural areas to connect the dots. And so I think that's just, again, we're doing, I think, again, the similar strategies. We're working together, linking arms, but at the Heart Association, we know we can do a lot of things nationally as the organization, but we also know that the commitment to having a grassroots infrastructure in communities will never change. It is part of the secret sauce that helps us do our work.
Grassroots, I agree. Well, I got a million more questions to ask you, but I'm getting a couple of questions in on the Q&A line. So I'm not going to be selfish. I'm not going to ask you my questions. I'm going to try to get to some of these other questions. There's one that plays off of everything we've just talked about, but it's specific for building trust with people who have multiple illnesses or multiple diseases, multiple comorbidities, and are over age 65. And just wondering, this questioner is asking, how do we prioritize that group's specific pressing questions that they have? So maybe I'll just open it up to any one of you if you have specific thoughts on polychronic comorbidities in the older population and how we meet their needs.
I'll take a stab at that one. Direct example, that is yesterday, our team met with Dr. Oz, the administrator for the Center for Medicare and Medicaid Services, in person in Nashville, Tennessee. And that was actually the topic of our discussion. So it's a very poignant question for today. How do we actually meet those needs? Polychronic disease, social isolation and loneliness. And so and it was at a local YMCA. And so we actually had quite a few of those folks that participate in Medicare in that part of the discussion, right? So not just us as the quote unquote experts leading that discussion, but we had a bunch of folks that we brought in to participate in that discussion. So it really is, again, this top down, bottom up approach, right? You have to actually have both. You have to have the roof of the house, you have to have the foundation of the house, and then you have to have the guts of the people that live there. And so that's what we're really trying to do. And I mean, that's a very simple explanation of what was going on, but it's a very complex question, right? How do we do that? And so, yes, there are programs that we have in place to address those things. But it's much more than that of just create a program and let it go. And both of all of these participants, all of these speakers know that very well. You really, really have to get that community engagement to hear from those that have those issues in order to address it. And what are those specific barriers? And those barriers are different one community to another. So it goes back to our other questions that we just addressed. Is we really need to identify those pieces. But we really must have the roof of the house, right? We must have government, federal participate in that because of the regulations that they're creating in order to have us allow us to access it from the bottom up. So I'll stop there and see what the other speakers have to say.
I think that's really good. That kind of sparked something for me that we're really leaning into, and this solving this problem of folks living with these multiple chronic conditions and trying to navigate something we're really excited about in terms of momentum in the marketplace. And to your point, Dr. Winters, what are these business models that they're going to sustain is the momentum around care coordination and some of these reimbursement pathways for care coordination and navigation now for people living with multiple chronic care conditions. So we're really monitoring that. It's sparking a lot of innovation with private companies doing more in this space now that there's a model to sustain. So we're thinking about, is the American Heart Association, can we play a role here in guiding, what coaching and curriculum looks like for gold standard care coordination, for example, and really fuel this issue, because we know it's so difficult when you're managing a couple of different conditions and bouncing in between specialties and trying to find your hub in primary care. There's no silver bullet, but we are really, again, encouraged by kind of the tipping point of new reimbursement pathways in this way, and leading into how can we further advocate for those things to proliferate more through our policy work that we do, and what are other ways in which we can fuel that through certification models and things like that.
Yeah. I mean, that I don't have anything better to add to that. I was going to lean into the pieces about the care coordination piece, and that just speaks to the importance of having the navigation and clinical and social navigators piece. I wanted to elevate some of the advocacy elements that can come out of that. So, no, the two ladies have summed that up very nicely.
Dr. Crank, now I'm going to put you on the spot because Michael Joseph, who's one of our audience members, wants to get tactical, which is how is the ADA and the AHA using AI in the clinical space to help detect patients that have chronic disease and maybe even prevent progression of chronic disease or prevent it from happening to begin with, or to treat it. So AI, I mean, I can tell you I can barely spell AI, but I'm learning a ton. It's like drinking from a fire hydrant because everything is AI these days. There's lots of promise out there. Wondering how you in the ADA, and then Juliana, you in the AHA, are using this for chronic disease care.
Yeah, that's a great question. That definitely does put me on the spot. I don't know if I'm even the best person to answer that, because we have had lots of conversations about being on this is the new thing, right? And we need to make sure that we are incorporating this in a positive and a meaningful way. Not very sure what that's going to look like right now. I'm happy to follow up as far as the community aspects of it and the implementation pieces, we certainly are exploring how can we use AI as, within our marketing and within our health education pieces. And is there a way to curate and create these AI interactions that maybe can be even implemented at a local level? I mean, is there something we can put in a church where people can interact and receive curated healthcare information? Again, nothing really tangible that I can answer right now, and I'm sorry, but I will certainly be able to be happy to follow up and see if we can get some information back to you, Dr. G.
Yeah, well, I certainly put you on the spot with that. I know it wasn't something we had planned on discussing, and
Okay.
it is all cutting edge right now. And so there's a lot of promise out there, and we're all just starting to learn how best to use it. Juliana, anything to add from a heart association standpoint?
Similar to Dr. Crank, it's early days for us, but we are kind of attacking it in similar manners in terms of we have convened a group of experts to help us think about kind of standards for use at the clinical level and setting those, while also looking for opportunities for real world implementation. I think particularly in the work that we're launching with particularly with ADA and DaVita and others with cardio, kidney, metabolic health, we're leveraging this new prevent risk calculator, and we're going into health systems to see how we can use that assessment to start to move people down this new kind of framework of care. And so we're talking to a lot of partners that are on the edge here that could maybe help us do some real world implementation to test out how can it be effectively used in a way that is efficient operationally, but stays true to the science and the treatment paradigms and all those sorts of things. So we're certainly out there testing and learning as quick as we can as things move forward.
Yeah, makes sense. Dr. G, and then I'll share how we're using it at DaVita, and then we'll get back to a little bit more specifics on community health.
Yeah, so I have a thought on that where the consumers now are the ones that are receiving all of these at-home tests. The consumers are now the ones that are using AI for their own diagnostic capabilities, right? So there's this interesting intersection of the trained practitioner and how we might use it. And then there's this other component of the consumer facing piece. And so as that consumer with their wearables, with their at-home diagnostic tests that, Amazon drops off and then you send it back in the mail and then they get their test diagnostic backs, whether it's a breast cancer screening, except prostate cancer screening, whether it's the mirrors that now tell us our blood pressure and our temperatures, our toothbrushes, our toilets, right? So if you think about this expansion of technology as a whole, not just AI, but as technology as a whole, I really think that that's actually going to change how the consumer makes their decisions, which will then actually change how we as practitioners are making our decisions in helping them to achieve the care that they're looking for. So there's a lot more to be said about that, and I've kind of dug into it because of the place that I sit in where I'm really navigating this consumer world more so even than as a practitioner anymore. And so that's really an interesting piece, and I kind of said it a little bit before of the foundation of the house, if that's data technology and platforms, and we know that it grows at this really exponential rate, how does that affect the house of where we're living and then the roof of the house as well? So there's that whole component to consider, not only just AI in this practitioner space, but in the actual whole of how that consumer, how it's leveling up from the consumer. And will that actually change the big block healthcare systems into more specialty care is where I actually have some thoughts about how that actually moves. And then it informs how we make our business models and our decisions.
Makes a lot of sense. There's so much promise for AI out there, obviously for individual patient care, but also for community care. And certainly the way we think about it is how do we take care in the community that can be somewhat fragmented, disjointed, and actually use AI to bring it together. So there's so much data out there about a given patient, from their hospitalization stay to their cardiologist visit to their nephrologist visit. And how do we use AI to package that and make it succinct so that the hospital doc, the nephrologist, the cardiologist, the endocrinologist, et cetera, are all seeing the same data at the same time so that we can break down those silos and help improve care for patients, ultimately providing clinical recommendations to providers as well. Hey, we know this about the patient, taking into context not just their clinical care, but their care out in their community, what they do for a living, things along those lines, and putting it together so that we can help provide recommendations to physicians about ways that they can continue to augment the care that they provide to patients. And then certainly with patient engagement, trying to do things like Dr. Crank mentioned, putting information at a patient's fingertips when they need it, where they need it, how they need it, so that they can consume information about themselves or about the illness that they're trying to prevent or trying to treat, so that they can be engaged in their care. So really, really exciting with all that is to come, both at a community level and certainly at a patient level. We've been talking obviously about the work that the AHA does, the ADA and YMCA and DaVita, but ultimately in many ways we're all working together, or at least we're trying to get to the same outcome, better community health initiatives. So would love to hear from you all about what good collaboration looks like and why it's so important. And maybe Juliana, I'll start with you. How collaborating with others is helping you move your message further in terms of good heart health and good brain health.
Yeah, absolutely. I mean, I think, we of course have this list of guiding values, and at the top of the list is powerful partnerships for the organization. And so we recognize that our mission and vision is large, to create this world free of cardiovascular disease and stroke. And we certainly cannot do that alone. So it's kind of, I think, built into our ethos to work across the lines of clinical and community-based organizations, to do this work. And it's not easy, right? It takes time, it takes deliberate care, it takes an investment, in staff and infrastructure, but it's really the only way we get things done. And so we do that at all levels through collaborations nationally, and how we do this work, and in communities. And we find that when we take the time to do coalition building and coalition-led work, just the outcomes are better. I was actually reflecting with Dr. Crank that just by happenstance, I got a recent report just on Friday from a collaboration that we've been doing in 11 markets across the country on cancer, with the American Cancer Society, American Diabetes Association, and the Heart Association. And just looking at some of the outcomes from that work is just by us partnering together as 3 organizations focused on prevention and screening, we were able to see referrals and community care triple, from where they were before, and screening, things like that. So really strong, impressive results that I believe are really attributed to the fact that we took the time and care to partner, to hear voices at the table, to build coalitions, and to lift up community voices that are really local, that don't always have the capacity to do what we have, and really focus on capacity building there, and bringing that forward. And one other, note from this report that, again, just came right in time to think about this conversation today, is policy was really important locally. We wanted to bring the power that we have as an organization that can work at federal, state, and community levels in policy, and equips organizations in the community that may not have had that experience before to do that kind of work. So we are hearing their voices now that we have done this work together. They feel equipped to sustain policy building, maybe without us in the future. And so we were able to build capacity into communities and sustain, because we took the time and the effort to start from the beginning and plan it all and see it all through. So I think it's just built into the ethos of how we'll do work, because just outcomes are always better when we partner.
Definite wisdom in the adage that if you want to go fast, go alone, and if you want to go far, go together. So appreciate that. Dr. Crank, same question to you in terms of collaboration and how that helps the ADA augment your message.
Yeah, absolutely. And the example Juliana just uses is just a beautiful example of collaboration at multiple levels, right? Because we have collaboration between our organizations and our partnerships that we do professionally, where we can bring together all of our expertise and the science. And then we have partnership at the community level, where we can the project that Juliana mentioned, the Collaboration for Equitable Health, We partnered as organizations, but then we partnered at the local level where we had impact partners in each of these communities locally that then can bring the trust and bring the reach and bring the connections to community members. And so when you get all of that together, you see the success that Juliana shared. So again, the collaboration is definitely important, but at multiple levels is the only thing I will kind of tease out from that. We want to make sure that, as far as ADA, we partner at all levels, and it's tremendously important to make sure we're amplifying those partnerships at the community level.
Absolutely. Dr. Winters, I mean, we do a lot of collaborating together, and I love it because we bring our expertise and you bring your expertise, and they're not the same expertise, and it's highly complementary. But would love to hear how you think about it with all of the organizations that you partner with. Sometimes you're the impact partner, to use Dr. Crank's term, and sometimes others in the community are the impact partner. How do you think about that?
Yeah, I think Dr. Crank said it really well. It's layered and it's teamwork. It's partnership, but partnership ought to be defined so that it is sustainable, so that it's not, if you will, throwing spaghetti against the wall and then not having it there the next year for those folks that needed it. So one of the first things to do, as I mentioned a little earlier, was really create a business model behind it to make sure that it's sustainable. And I loved that Juliana was talking about that it's at the federal, the state, and the community level. So that actually needs to be the intrinsic part of this business matrix as you go forward. And that's oftentimes what we see with a community-based organization is sometimes we're a little smaller and maybe don't have that kind of sophistication or savvy from the front end. And so helping that community-based organization to build that up in order to do that, I think is really important for the other partners to win in it as well. One of the examples of that is with you, Dr. G, and DaVita, of course. And so in the collaborative community kidney health program. Say that 5 times fast. Collaborative Community Kidney Health Program. There, I got it. We've built that partnership with DaVita and launching across 7 of our large YMCAs across the country. And that's all about closing the gap between the kidney health education, empowering early risk detection, really letting the community know that this is a key piece for decreasing CKD risk factors. And so this is a really powerful thing. And what we did was we actually had conversations at the national level, and then we found local YMCAs that were really needing it, such as in Baton Rouge, as you just mentioned earlier in the call, where there's a really high prevalence of this issue. And so we were able to layer that over, market map it to see where the need was, and then drop that down into our local associations. But that was really part of the strategic business plan in order to do that, so that we can actually see that it achieves more health outcomes and reaches more lives than we had thought possible.
I want to dig into that a little bit because this more health outcomes, more lives, that really is the theme here. So on the one hand, we started out by saying, look, care is local. You got to know the individual community, and what works in one community may not work in another community. I think we would all agree with that. And then I had a question, and one of our audience members, Rahul Razdan, had a question that's kind of the same. So I'll pose it to you using both of our words, which is, if care is so local and we've got to be focused on an individual community, but we want to have impact across the entire United States, and in our case, not just at 7 YMCAs, but ultimately at lots and lots of YMCAs, how do we actually scale this? So how do we take what we learn in an individual community and then move it beyond just that community and scale it in a manner that truly makes an impact for healthcare across the country and maybe even across the globe? So maybe I'll just go back to you, Dr. Winters, and ask you that, and then we'll go over to Juliana and then Dr. Crank.
Yeah, love it, love it, love it, right? Because what we haven't done, and I say we, the YMCA historically, we're now going to be 175 years old next year. What we haven't done historically, and 2,700 locations within 70.
The HLTH is only 100 years old. No. So you guys, you got some catching up to do.
We're so good.
Yeah. And I mean, if we're within 73% of any given community across the country, like, we need to figure out how we can create an engine that actually measures health and wellness and prevention, right? We have a hard enough time measuring sick care and the outcomes there. How do we measure health and wellness and prevention? We all know that it works to eat healthy, have healthy lifestyles, have good, all of these things, right? Behavioral, physical, socioeconomic factors. How do we actually measure for that? And so one of the things that we've done is create an engine that actually centralizes for all of our YMCAs. It's a shared service engine. And that is part of that business model that I keep alluding to that actually allows us to centralize. Within that engine, we actually have an electronic wellness record system. So everybody knows an EHR, an EMR, right? This was actually created for us as a community-based organization. It's really the same thing, but it's an electronic wellness record system that can actually grab outcomes. So this is the piece that as we work together with all of you, we can actually centralize that, not just for one association, not just for all 7, but all of the Ys that are participating. And this is obviously not just for the YMCA, it can be for other community-based organizations, so that we can actually extrapolate this information, health and wellness and prevention data, connect it over to sick care data, and actually show we're decreasing the cost of sick care. We're improving the health of these folks that are costing $25,000 a year and surplus, right? That's really going to be where the power of the future of health is, if and when, and we are starting to do that, being able to connect that information. And hopefully, I don't know that it will change our $4.9 trillion spend, but what I think it will do is actually help to increase what we are spending in the health and wellness and prevention to make it more powerful for that downstream sick care component.
Well, same question to you, Juliana, in terms of getting to scale.
Yeah, it's a question, and that was amazing to hear, Dr. Winters. I'm so excited to hear kind of what we were able to build from a data perspective. I'm hoping we can chat more offline about that. But the way we think about this a lot, like what's that balance of systematic delivery and the framework that we need for local, local customization. And so some of the ways in which we really think about that, and we're doing this in our cardio kidney metabolic health now, is kind of mega pilots. We have a long history in clinical quality improvement and working across healthcare systems to improve measures on quality of care for coronary artery disease and stroke and heart failure and these other things. And now we're embarking on this journey with cardio kidney metabolic health. And so we do this work through a clinical quality improvement program that rolls out across the country. Well, for now, we're working in 15 geographic regions. I can't say cities because in rural, we're taking kind of swaths of the country, but largely 15 markets or areas of rural communities with enough variation to test the work. And so to test the delivery of quality improvement programming and gathering the healthcare systems that are participating in learning collaboratives to learn from each other. So we're able to figure out what is the right level of customization that needs to happen in the healthcare system, and what are the commonalities that we're learning that can be more systematically delivered to figure that out. And so if we can do this in this mega pilot type fashion where we have hundreds, hopefully 150 or so healthcare systems that are operating like this and sharing best practices, we're able to suss out the systematic parts of delivery and then where there is need for local customization for the community. And we do that in a data-backed way too, because every quality improvement program we roll out has a registry behind it. So there's data there, and then we're looking for that sweet spot of the consistent delivery and where the community-based models need to come in for customization. It's a tough.
I can tell you, I just learned a new word. Mega pilot was not in my vernacular. So trust me, I'm stealing that. Mega pilot is going to now be a DaVita ease a little bit. But I think what I hear you saying is, look, there's this constant balance and a little bit of push and pull. There's some stuff that should be standardized and rolled out to everyone because it works. It's a best demonstrated practice and there's no reason to reinvent the wheel. And then there's stuff that we need to customize, whether or not we're in, southern Mississippi or northern Massachusetts or somewhere on the West Coast, that depending on the community, there's some areas that we need to customize. What about for the American Diabetes Association, Dr. Crank? How do you think about scaling? I just spent time in Chicago at the big ADA scientific meeting. The scientific sessions were amazing. So I know how you're scaling to physicians and dietitians, but how are you scaling more broadly than that?
Yeah, that's a great question. And when we think about scalability starts really with designing programs with equity in mind, right? Not just reach. And so if an initiative isn't necessarily inclusive or sustainable at a local level, replicating that nationally, it really can amplify the inequities in it. So one of the strategies, other than what these ladies have mentioned, is focusing on local capacity building. So making sure that when we do the program design, it's anchored in a framework where the process works. So, kind of zooming out a little bit and looking at the process. So the details in it may change. So if we start with community engagement, what we fill in the blank later may change a little bit, but the process is for us to start with community engagement and to start with these qualitative um, forums where we're intentionally engaging communities to build that into the program design. Also into the program design, making sure that we're including local capacity building. So training community health workers, creating a local feedback loop that may work. You can insert anything right there, right? Because it's the design and it's the model. A feedback loop with clinical partners there locally. Again, both qualitative and quantitative impact measurements that can really guide the future of how that program is implemented. An example of that is really some community hubs, again, that we're doing with in obesity and the diabetes space, but ensuring that the design of that, so no matter where we pick it up and do it geographically, it may look different at the end result of what that hub looks like, but the process of how we implement that allows us to be able to scale these hubs, in a way that our process may work and be effective and scalable in different geographies.
Awesome. So, Dr. Winters, I want to go back to something you said earlier, which caught my attention, which is basically, I'll probably paraphrase it wrong, but it's moving from sick care to well care. And Gary Conkright, one of our audience members, brought up something similar. So how are we each thinking about doing that, moving from sick care to well care? And then specifically, Gary's question was around how are we engaging the federal government in policy change or advocating for things that allow us all to move upstream to get ahead of comorbidities before they become big issues? And so are there anything you're doing? I've heard from all of you a little bit of some of the work that you've done at the national level, but would love to hear more about what you're doing from a federal policy or advocacy standpoint to move from sick care to well care. And maybe we'll start with you, Dr. Winters, and we'll go to Dr. Crank after that.
Yeah, that's a really good question. And it's a thick question, right? There's a lot of work to be done to move from sick care to healthcare. One of it is first really understanding the fragmentation of our system. When you know what the problems are, then then designing the solutions from that place is easier. So I've spent a lot of time on that. We have at the YMCA of the USA and at our local levels, government and advocacy folks who are working on this every day, all day. We actually have an office in DC. And as you just heard me say, had the opportunity to meet with Dr. Oz and his team yesterday in person. So those are some of the things that we're actively working on every single moment, if you will, to really advance this work in health and wellness and prevention. I heard a speaker say just the other week, we're trying to tell these folks in the government that water is wet, meaning, health and wellness and prevention works. And while I didn't really like that, it's true, right? There's pieces of that because we haven't proven it. It's a little bit non-tangible because we haven't had the data to say this is actually what health and wellness and prevention does to decrease sick care. And so I think that's, again, one of the key components is the ability to provide outcomes in this space as we all collaborate together to say, this is what this work with these different organizations did to prevent cardiovascular, diabetes, all these downstream chronic diseases. That's going to be really powerful. We have some great evidence that's already coming out, but we need to even have more of that at scale. So it's that both and, right? It's the top of the framework of the house, it's the bottom up, and really collaborating together. Again, a lot more to be said about that, but I'll let my other colleagues impart their wisdom.
Yeah,
Dr. Crank, and then if we have time, Juliana as well.
Yeah, I'm happy to jump in and I'll be brief. ADA has huge investments in the advocacy space. That's something that's certainly a pillar of our organization and the work that we do. There's active engagement going on at the federal, the state, and the community level, really. Some of the priorities that you'll see coming out from ADA advocacy really is in insulin affordability and access. The insulin cap was a huge win for us here recently. Healthcare access, so coverages under Medicare and Medicaid, and even into the AOMs and obesity coverages, lots of activity and advocacy going into that space. In the space of research and research funding, there's lots and lots, again, of increased funding going in for diabetes research. And then those individual rights and protections, right? Fighting discrimination in schools and workplaces, employment, and, things that are affecting people living with diabetes and obesity at an individual level. And then, of course, the grassroots advocacy. So ADA has, gosh, probably hundreds of thousands of grassroots advocates all over the country that are implored to really work on the community level to build up the capacity of communities to know how and where to advocate and share their stories and be able to take this information and help make policy advancements at the local, state, and even the federal level.
Excellent. All right, Juliana, in 1 minute or less.
Yes, the only maybe similar, our federally policy agenda is rapidly evolving, to within the current marketplace, and lots going on there. But maybe the tangible example I'll have where I feel like we actually have some really strong connections with the priorities of the current administration is around food as medicine. And so it's really exciting to see there. We have a large scale initiative and investment from many partners to help us. Again, water is wet, food is medicine. We know it improves health outcomes, but the economic return, that is what we're really studying. And so to really push for wide scale reimbursement, and we're seeing a lot of momentum at the federal and state level. So I know that's just one piece of a lot of things we need to do for prevention, but it's a really big bright spot in seeing momentum and support for those types of programs, and just pushing that economic case forward is what's going to move us forward. And we're committed to pushing that out and doing that through the work that's going on.
Well, I'm grateful to each of your organizations for the advocacy that you do. We are similarly involved in advocacy at a high level, advocating for value-based care. How can we think about holistic care, taking care of the whole patient, not just their kidney issues, not just their heart issues, not just their psychosocial issues, but bringing that all together, because whole person care is the way that we move from taking care of patients episodically to truly taking care of them as a human being and having those connections. So I'm grateful for all of the work that you all do. All right, we've got 2 minutes left, so I'm going to do a very quick round robin. You each have a magic wand, and you get to do one thing with it to improve the care or the relationships you have with communities. So maybe we'll start with you, Juliana. What do you use your magic wand on?
Well, if I could have a magic wand to help us do even better, it would be some sort of tool that would allow for the consistent data collection to kind of pull up in a consistent way and marry that data at the community level with all of the great stuff we have at the clinical level. So that's my magic wand. So many good things, but it's hard to often get the consistent data piece in there. So that's my magic wand.
Actionable data. All right, Dr. Crank, really quickly.
Yeah, my quick magic wand moment will be taking some of these programs that we've done so successfully, and I'm just going to wave it and have a scalability and have everybody everywhere understand how important community engagement and intentionally involving communities in the planning of programs that involve them, the successes that can come out of that, and just have that blow up widespread till we work ourselves out of a job.
Awesome. All right, Dr. G.
Well, the beauty is I just say ditto to that. What I was going to say is a magic wand that actually just creates this funnel that just brings these lives in, right? We just need to grab them and pull them in. Once we pull them in, relationship, trust, all of those components actually just allow us to more effectively improve their health. But it's this grabbing those folks and putting them in a funnel.
All right. Well, it is the top of the hour, so we're all going to turn into pumpkins or whatever the analogy to magic wands are. But my magic wand is just to have more collaborators like you all. I just am so grateful, Juliana, for the work that we do with the American Heart Association, and Dr. Winters, the work that we do with the YMCA, and Dr. Crank, the strong partnership we have with the ADA. So that's what I'm using my magic wand on, is more time from each of you. So appreciate it. And to the audience, thank you for sending in questions. I apologize we didn't get to all of them, but just really excited to be here and share these ideas with you. So be well. Thank you.
Thanks, everyone.
Thank you to Davida and to everyone that joined us today. Please visit our website at community.hlth.com to catch up on all health webinars and to watch the recording of today's session. And don't forget to join us in Las Vegas, October 19th through 22nd for Health USA.